Through a review of national and local trends, Magellan Behavioral Health of Pennsylvania identified a need to explore additional opportunities to improve care for our forensic-involved members. Magellan partnered with 2 consultants to identify potential provider training opportunities to improve forensic-based behavioral health services. Feedback from providers and criminal justice stakeholders indicated a need for training in the following areas: key criminogenic factors, forensic evidence-based practices, social determinants of health, and the Risk-Need-Responsivity model. To meet this need, Magellan released a series of micro-webinars addressing these topics. The microwebinar you are about to listen to will address the Risk-Need-Responsivity model.
Okay. Good afternoon, everyone. My name is Rich Pajeski. I'm a Director of the Bureau of Offender Reentry for the Pennsylvania State Board of Probation and Parole, and I'm here today to talk a little bit about evidence-based practices in community supervision, and specifically about risk, need, and responsivity factors. Today, specifically, what I will speak to you about is I will review the NIC's, which is the National Institute of Corrections, Principles of Effective Intervention. There are 8 of them. In this first presentation, I will focus on the first 2 foundational principles and their importance in enhancing community supervision's ability to protect the public. I will also talk a little bit about, in this presentation, what staff can do right now and in the future to benefit from using evidence-based practices and knowledge of risk, needs, and responsivity, to promote the idea of evidence-based practices and risk, needs, and responsivity, not as a distinct program, but a way of doing business. In my world of reentry, we think of the reentry of an ex-offender or a reentrant back home to the community as a process, not a program. And that's an important distinction because it's about transitioning the offender from a state of incarceration to a state of living at home and reintegrating themselves back into the community. A little bit of background. The state of affairs in corrections in generally speaking, rearrest rate for offenders under supervision are nearly the same for those offenders who have unsupervised sanctions imposed. More than half of all correctional programs evaluated via a CPC are deemed ineffective. What a CPC is it's a term that stands for the Correctional Program Checklist, and it is a tool that allows us to measure the program and their adherence to the principles of effective intervention. From a statistical standpoint, recidivism in Pennsylvania, according to the Department of Corrections, research shows that recidivism rates are stable, but rearrest rates have been slowly increasing. More recent recidivism data are showing decreases in recidivism. Our research here at the State Parole Board shows a 1-year recidivism rate decreasing from 21.8% to 19.2% from fiscal year 07-08 to fiscal year 14-15. And we think that is largely due to our application of several principles of effective intervention, several evidence-based practices that allow us to do that. To illustrate some of this, just as a basic definition, evidence-based practices, the National Institute of Corrections defines EVP as practices that are progressive organizational use of direct, current scientific evidence to guide and inform efficient and effective correctional services. The Reentry Policy Council defines evidence-based practices as interventions and treatment approaches that have been proven effective through a rigorous scientific process. In the context of reentry, this often refers to a practice that has a demonstrable positive outcomes, meaning that the practice has lowered recidivism rates. A little bit of history about evidence-based practices. If we remember the work from Martinson, mainly that was from nothing works to what works. NIC began promoting the what works philosophy in the 1990s. And we have to understand that today it's not necessarily from nothing works to what works, but more importantly, it's what works with whom. And that's where risk, needs, and responsivity comes from. It It is what intervention works with whom. So I think historically we saw the development from, the 1960s through the 1970s, and that pendulum swinging from nothing works to what works, to today we see what works with whom. And we in the correctional system promote the idea that evidence-based practices is not just that swing of the correctional pendulum, because sometimes we often see that. We often talk about, oh, this is the latest fad, and this is what we're doing now, and it's going to go away in a couple weeks. Not so with evidence-based practices. Not so with the principles of corrective or the principles of effective intervention. Not so. A little bit about research. There are basically 5 different types of research associated with evidence-based practices. We have obviously it starts at the foundation of what we know doesn't work. It moves through what they call iron, which is inconclusive research. There is promising evidence-based practice, a practice that is pretty much based on the empirical observation of people. There is the silver level of research, which is usually characterized by research that utilizes a match comparison. And then there is the gold level of research when it comes to evidence-based practices that is what people and researchers strive for, which of course is the randomized control groups, the RCT method of conducting research. For something to be designated as an evidence-based practices, and this comes from the Washington State Institute for Public Policy, it must be tested on an appropriate population. It must be on a correctional or an incarcerated or a community, a supervised population. There must be multiple evaluations using solid methods, or one large multi-state evaluation using a solid method, similar to what I just showed you in that previous slide. That gold level of research, that randomized control group is what we strive for. That the research can be replicated, and of course that the research is cost effective. So here's a slide that represents the 8 principles of corrective intervention. As you see, the foundational piece of EBP is risk needs and assessing for actuarial risk. That is something I'm going to talk about in a couple slides in more detail. The second level is enhancing one's intrinsic motivation. And what we're talking about there is we're enhancing one's intrinsic motivation to change. And that is not the easiest thing in the world to do. We enter into the third one, which is the next presentation, which is targeting that intervention. Targeting the intervention to areas of criminogenic need, meaning areas of need that cause crime, and more importantly, targeting medium to high risk offenders who are at greatest risk of recidivating in the community. The fourth principle is skill train with directed practice. You must always skill train your staff in what it is they're doing, and they must practice what's called directed practice in terms of targeting the right person with the right intervention. Increased positive reinforcement is the next principle, and that is reinforcing with the offender that they are doing a good thing. They are changing. The ratio is 4 to 1, and I will talk about that in subsequent presentations. And then the final one is engaging ongoing support in the community. It is so important for offenders as they return to the community to have support structures in place for themselves. It is so important to have those community resources. So when we look at these principles, we can through resource or research look at the recidivism rates of both a custodial environment, meaning an incarcerated environment, and a community environment probation, parole, and correctional organizations that employ these principles of effective intervention. And as you can see, if you just do one principle, you can have a positive impact on recidivism. If you try to employ two principles, you can have up to a 12% to a 22% impact on recidivism in both that custodial and the community environments. If you're fortunate enough to be able to employ 3 evidence-based practices, you can see a 0.17 impact on recidivism in a prison environment, and a 35% impact on corrections populations in a community setting. So the more principles an agency is able to employ, the better impact they're going to have on reducing recidivism. And that's a very, very important thing to understand. So risk, needs, and responsivity. In a nutshell, the risk principle is who? Who are we targeting for correctional intervention? We want to target those higher risk offenders. We do not want to necessarily target the lower risk offenders. And there's a reason for that. And I will briefly touch on that in subsequent slides. The need principle, what to target. Individual offenders assess criminogenic needs, those needs that are related to crime and that can be impacted by community interventions. And then responsivity is the how we target. Generally, we in our field use cognitive behavioral interventions, changing the way people think. Changing the way people think is not easy work. Specifically, we look to match interventions to relevant offender characteristics that impact their ability to participate in and benefit from derived treatment. So it's the risk, need, responsivity, or another way to think of that is the who do we target, what do we target, and how do we target it. There's a fourth one that I like to talk about, and it's called how well. It's called fidelity. How well do we deliver the intervention, and whether or not we're delivering a quality intervention for that individual in the community. Some statistics about relationships. If we remember from graduate school, we talk about correlation coefficients, right? We talk about Pearson's R and Kramer's V, and here are some commonly held, well-informed social common belief policies that are what I would say related to the medical community. Heart bypass and 5-year survival rates is correlated at a 0.08 level. And if you remember from grad school, a correlation coefficient is the strength of the relationship between two variables, right? And the closer you are to 1.0, the stronger that relationship, right? So the use of ibuprofen and reduced pain, a 0.14, it's getting stronger. A mammogram and cancer detection, 0.27. That's a moderately strong relationship. But suffice to say, these are things that we have embraced as well-informed sort of knowledge within the medical field. When we look at what the science says about the principles of effective intervention, we look at the relationship between a cognitive behavioral treatment and reduced recidivism. The correlation is 0.29. That's a pretty darn strong correlation. The use of an actuarial tool as a predictor of recidivism, a 0.30. Addressing those antisocial attitudes in companions and recidivism ranges from a 0.18 to a 0.39. And more importantly, the highest one here, targeting that criminogenic need and reduced recidivism correlates at a 0.55 level. And that is just really, really high, that if we do a good job utilizing risk, needs, and responsivity and incorporating these principles of effective intervention, we can really, really, really have an impact, a positive impact on reducing recidivism. And when we do that, we really make our communities safer. And that's what we're in business to. So again, just to illustrate one more time, when you adhere to up to 3 principles, you can have a 26% reduction in recidivism. And that equates to safer communities. It is good stewardship of the taxpayer dollar, and that is where we strive. Agencies will strive to incorporate all of the principles, and that is difficult to do. But if you just do 3, you can have a big impact on recidivism. So principle 1, assess actuarial risk and needs. It basically boils down to mechanical assessments versus clinical judgment. There are several generations, as I call it, of assessments out there. There's first generation, which is mainly an unstructured clinical judgment. It's that gut feeling. You know, I've been doing this job for 30 years, and I know this person's going to go out and use again, or I know this person is going to go out and steal again. We have that second generation, which only looks at static risk factors. And static risk factors are those risk factors that cannot change. You have static and dynamic risk factors. A static risk factor is something like criminal history. It cannot change. The third generation instruments are mainly dynamic risk and need factors based on both theory and statistics. So the third generation has static and dynamic risk factors. An example of a third generation instrument is a level of service inventory revised, which is one that we currently use here at the State Parole Board now. And then last but not least, we have that fourth generation that incorporates both dynamic risk and needs and responsivity factors with built-in case planning based on theory and statistics. It sort of takes us to that next level of what I like to say, connecting the dots. We have information about assessments, we have information about areas of need, but what do we do with them? What is our next step? And that next step is case planning. How do we figure out how to connect the dots in terms of a person's risk, in terms of what they need, how we deliver it with responsivity in a coherent, structured case plan based on the available community resources that we have. Here's some statistics on parole success and general recidivism, violent recidivism, and reincarceration. When you just use that clinician, when you just use that first generation gut feeling, right? In terms of predicting parole success, they get it right 41% of the time. General recidivism, again, 41% of the time. Violent recidivism, 43% of the time. And reincarceration, 43% of the time. So that's sort of just like flipping a coin, right? Not to say that that person's experience is not worth anything. It is invaluable, because the purpose of an assessment is to inform your judgment, not make the decision for you. And that is a critical point. When you incorporate an LSIR assessment, when you incorporate an actuarial assessment into the picture, look at what happens to parole success and general recidivism. Well, they jump up to 60 and 70%. So utilizing everything you know about doing the job and then using an actuarial assessment, preferably a third or fourth generation, to inform your decision making increases your likelihood of predicting recidivism. And when you can do that, you can respond accordingly in community supervision. So with results like this, relying just on clinical judgment instead of using an actuarial assessment is not only unscientific and irrational. William Grove and Paul Meehl from the University of Minnesota called it unethical not to use the data, not to use the information that actuarial assessments provide for you. They called it unethical. Principle number two, enhance intrinsic motivation. Science shows that changes are lasting only if the subject intrinsically desires to change. External controls can only promote short-term change. That's why we see those studies like Scared Straight really prove to be ineffective over time. Motivational interviewing is a method It is an evidence-based practice. It's an example of an evidence-based practice that this style of communicating with people has proven to promote movement of individuals through the various stages of change. Motivational interviewing is an evidence-based practice. It's an example of an EVP that when a practitioner like myself becomes good at it, we can walk a person through the various stages of change. And here are the stages of change in a person's life. They're either pre-contemplative. That means they're not even thinking about changing. They are contemplating. They're thinking about change. They are planning to do something about a risky behavior or possibly a drug and alcohol problem. They do something. They take action. They enter into a maintenance phase. And possibly, as we know with the addiction cycle, relapse is part of it, and that does occur. But these are the stages of change that everyone goes through, whether it's a correctional population or not. And motivational interviewing is a way that we can influence someone's intrinsic motivation to change in a positive way. So in terms of risk, needs, and responsivity, I will then go to the next part 2 of this presentation in a minute or two.